Touched on this a little bit already. I don't want to overstate this, but you know, I have my missions in life, and so I may overstate this, but I really believe there's a moral imperative for employers to move in this direction, because I really do think it increases the quality of care by directing people in the right way and encouraging them to better health and improves their lives. And I think there's the economic imperative that it saves money, and these days lower product prices can mean jobs that are saved as well. So I think there's a lot of real strong imperatives to move in this direction and to make it work for your company. I'm going to skip through a lot of these. You can go back and look at these. There are some questions on the exam about the objectives of consumerism, so keep that in mind. These are some of the things that are appropriate objectives of changing the purchasing behaviors, narrowing the cost and quality variations in a given market, reducing both short and long-term costs and acute costs. So a whole bunch of them here. I believe strongly in these two basic requirements for healthcare consumerism. I believe that if it works, it has to work for the sickest among us. The earliest complaints about consumer-driven healthcare was that it was only for the young and healthy and wealthy. And there was, in fact, some truth to that. If I'm a diabetic, I don't want a high-deductible plan that was developed by Definity and Luminos, the real pioneers in this area. I want my full coverage HMO. But that's what I'll call first generation. I'm going to go through the generations with you. We don't sell first generation products for the most part anymore, and I wouldn't recommend somebody do that. What we're all actually already deeply into, is what I call a second generation, a focus on behavioral change. So that diabetic, if they're taking care of themselves, if they're following their doctor's orders, taking their medication, they're much less likely to what? Have their foot amputated, go blind, be rehospitalized. A diabetic who's stabilized is a whole lot cheaper than one who's not. So rewarding and incentivizing that diabetic, what if you gave them $100 a month for meeting certain metrics, following certain standards? They don't have a high deductible plan. I hate that term, high deductible plan, because it may be zero deductible. If you rewards incentives, fill that in. But legally, when we established HSAs, you had to have, with capital letters, high deductible health plans. So HDHP is legally defined. But sometimes that gets confused with the lowercase high deductible health plan, where there isn't the rewards and incentives. There's no accounts there. There's no way to decrease that cost sharing part. So we didn't have those when the products were first introduced, but we had to have a starting point. It was a good starting point. That's why you only had 3, 4, 5, maximum 10% of your employees enrolled, and it was the healthier employees. But as you change to second generation products, you got greater penetration. So we've overcome that. But that myth is still out there for people who don't want to go this direction, that are concerned about it. And so that has to be addressed in your organization, that you're doing something that's going to help the sickest of your employees. And if you don't put together a program that helps the sickest, then you're wasting your time anyway. But it also has to work for those not wanting to get involved in decision making, as well as those that do. Not everybody wants to spend their time on the internet checking what the lowest price of a prescription drug is. Not everybody wants to go and check out what the lowest cost hospital is. Why? Maybe they've got better things to do. Maybe that person is about to close $1 million commission deal. It's a better use of his time. Maybe they want to spend time with their kids on vacation or a baseball game. And that's more important to them than getting on the internet and checking out the lowest price. I liken it to somebody going in to buy a car. You walk into a dealership, one person has checked all the consumer reports and done all the background. He's got a whole stack of paper. He knows what every single accessory costs. And he walks in, and he's going to get the best price because he knows what things cost. He's going to be able to negotiate. Somebody else walks in and pays sticker price. They both got a car. They both got the transportation they're looking for. One got it cheaper, one paid more. Healthcare, in my opinion, ought to be the same way. If you don't want to do those things, fine. You pay more. You won't get the benefits of the rewards and incentives, but as with HSA eligible plans, your maximum out of pocket is what? $23.50, $63.50? So you're not going to lose your home. You're not going to lose your kids' college education. You're not going to go bankrupt. So a good, comprehensive, major medical, healthcare consumerism-oriented product ought to have a maximum out of pocket no greater than HSA eligible plans, which is what's in the Affordable Care Act as well. So if I don't get involved, that's fine. I just pay more. I don't know anybody who would really object to that because they got better things to do.